Good evening, everyone. A warm welcome to you all to this Liver Matters virtual discussion on the redefining management of HCC. I would like to invite Dr. Vamshi Krishna, sir, who is the head of Department of Medical Oncology at AIG Hospitals, Hyderabad. Dr. Vamshi has been a leader in advancing cancer treatment. Sir, over to you, sir.
Good evening, everyone, and thank you for joining in. I think Dinesh and Rosh have been on a one-man mission to make sure we don't forget about the HCC. We seem to have these meetings regularly. So this is one more installment in updates of hepatocellular carcinoma, and I think we are already running 5 minutes late. I request all the speakers to stick to their time. First speaker is Dr. Krishna Chaitanya, who will be speaking on role of immunotherapy in HCC. So over to you, Dr. Chaitanya.
Good evening, sir. Thank you so much for the opportunity. And I will be discussing the role of immunotherapy in HCC. Let me share my screen. I hope, Dinesh, it's visible.
Yes, sir, the screen is visible.
Right. Yes, thank you so much. Yeah. So I thank once again Rosh for providing this opportunity, and thank Vamshi sir. Let me go into my topic, role of immunotherapy in HCC. So we'll be discussing this in three sections. That is role of immunotherapy in the advanced HCC, and immunotherapy in intermediate HCC and early HCC. So coming to the problem of HCC, it is the 10th most, 1 minute. Yeah. So this is the 10th most common cancer type in India, and the 8th most common cause of the death. You can see it is the second most common cancer causing death in men, and most of the cases in India are because of the hepatitis virus. Either it's hepatitis B, most common, and the HCV. Whereas in Western countries, it's because of the alcohol-induced cirrhosis, where it will cause chronic hepatitis followed by cirrhosis and the development of HCC. So coming to the topic per se, that is immunotherapy in advanced HCC, we follow the standard treatment staging, standard staging in HCC, that is BCLC staging, where they divide them into very early stage, intermediate stage, advanced stage, and terminal stage. So we discuss the role of immunotherapy in the early stage, the intermediate stage, and as well as the advanced stage. You can see the advanced stage where there is a clear-cut metastatic disease or a portal invasion, where they fall into advanced stage, where they directly need a systemic therapy. Whereas in intermediate stage, whichever there is, the commonly seen in your clinical practice, wherever they're not falling into early stage, not falling into advanced stage, they fall into intermediate stage, and it's a very heterogeneous disease that also we'll discuss. So coming to the advanced stage, the role of immunotherapy, these are the first line therapies, approved, that is Atezo-Bev and Durva Tremelimumab. If they're not feasible or eligible for those therapies, you can go for a TKI. So this we see the evidence-based treatment. So the Atezo-Bev treatment, the basis is IM Brave 150 trial. It's a phase 3 open label trial because it's an oral medication versus the IV medication. We have a locally advanced or metastatic HCC, performance status equal to or less than 1, Child-Pugh status of A. And in this study, you can the important things are they have included even the high risk patients, that is having macrovascular invasion. 50% had a huge hepatic burden and main portal vein invasion. These things are excluded in the other contemporary studies. So that is the importance of this study. And here you can see the comparison between the Atezo-Bev versus the sorafenib with the endpoints of overall survival and PFS, which has met by the combination regimen. You can see the median overall survival of 19 months versus 13 months with a hazard ratio of 0.66 for the overall survival, and even the PFS is also the superior. The combination Atezo-Bev is superior to sorafenib. The confirmed overall response rate is 30%. This is the highest which we can see in any of the treatments in the HCC. And the treatment-related adverse events are almost equivalent between the two arms, and the discontinuation is not much higher compared to the sorafenib arm. So whoever respond well, the overall survival is much higher, who has good responses. This is the comparison between the good responders who has at least a CR or a PR, are the people who progress with this regimen atezolizumab. They have a very poor survival. You can see only 6 months with that, but it's not reached even after the like 3 years of follow-up. The median survival is not reached. So there is the people who respond well to the atezolizumab initially, they are going to do well. That is the point in this. And the coming to the adverse events, the hypertension, proteinuria are because of the bevacizumab and altered ALT, AST, and all maybe immunotherapy. Whereas in sorafenib it's because of the HFS and the diarrhea are because of the sorafenib TKI. So the even patient reported outcomes are also good, for the atezolizumab compared to the sorafenib. So all these slides I have taken from CCO. I forgot to mention that. Okay, so with this, we can say that atezolizumab is a superior treatment compared to the sorafenib. And coming to the second option, that is durva and tremelimumab. Here you can see it's a phase 3 trial where 3 arms are there, but the comparison is mainly between the combination of tremi with durva compared to sorafenib. And this primary objective was overall superiority comparing these 2 arms. And the durvalumab single agent is also there, where it was to show that it is non-inferior to sorafenib. It was powered to show that it is non-inferior to sorafenib. So this trial has shown an overall survival benefit of 16 versus 13.7 months with a hazard ratio of 0.78. You can see here the PFS, there was no difference, but the overall survival, the statistical significant difference. That may be because of the addition of the CTLA4, which generally has a long-term survival benefits. That is the only thing which I can explain why we got the overall survival without getting any PFS benefit. Immunotherapies will give overall survival benefits, and almost all the trials will include overall survival as the primary endpoint, because we don't get the short-term PFS benefits with this most of the studies. So with that, even the updated 4-year survival, we can see the similar, no separation of the curves between the stride, that is the combination of durva-tremi versus the sorafenib. Whereas the single agent is not inferior to sorafenib. It was not significant, but it was not inferior to it was not significantly superior, but not inferior to sorafenib. So with that 2 studies, we have approvals of atezolizumab in the first line as well as the durva-tremi. But whoever is not fit enough for bevacizumab, definitely durva-tremi will be an option. Atezolizumab has shown a very good response rates and huge tumor burden, very high risk disease where you would need much responses. I think atezolizumab should be the preferred option compared to the durva-tremi. Durva-tremi, you can keep it for a very, low burden disease, slow progression. In those cases, we can keep durva-tremi as an option. Whereas the other options like combination of immune checkpoint inhibitors with the TKI, they have given only the PFS benefit. There is no overall survival benefit. And even the addition of pembrolizumab to the lenvatinib, it did not give any kind of PFS or the overall survival. So we have only the atezolizumab and the combination immune checkpoint inhibitors as effective therapies. The other therapy would be nivo-ipi combination, where the 3 doses were checked, and the arm A has shown a median survival of 22 months. You can see the response rates of 32, which is equivalent to the atezolizumab arm. So this regimen has been compared with the sorafenib and lenvatinib. This is the new study, CheckMate 9DW, where they have shown the combination of nivo-ipi and then followed by nivo maintenance compared to the either lenvatinib or sorafenib, with a primary endpoint of overall survival. They have the best survival which you have seen in HCC. Though these people didn't, this study didn't include much of, portal vein thrombotic patients compared to the atezolizumab, but still the survival is much higher for the, the combination compared to any of these arms. So these, you can see the single agent lenva sorafenib also had a median survival of 20, which we don't see in the TK studies. It was only around 13 months and 16 months like that. But in this study, it is almost like 20 months. Maybe it's been, the disease is also like evolving. And the objective response rates, you can see 36%, whereas 30% in the atezolizumab arm. So most of them had the very good responses. So it's a very good regimen, maybe, compared to the atezolizumab, even though the numbers are better, but the inclusion criteria for this atezolizumab study is much better. They have a very high risk patients, portal vein thrombus patients, very high tumor burden. So atezolizumab probably would be the preferred in the clinical practice. So coming to the second one, that is in the intermediate HCC. So we have checked the metastatic. Now we'll go to the intermediate stage HCC. So it's a very heterogeneous disease. You can, whoever is not fitting for early, that is a single tumor or less than the nodules less than 3 centimeters each. So, or the portal vein invasion or a metastatic disease, all of them will fall into the intermediate stage. This is the most common stage what we see in the clinical practice. So they won't have a major portal vein invasion, they don't have a metastatic disease, but it will be like an incurable, in the sense it will be like a multinodular disease in the liver. So in this we have to make out, blindly, rigidly we can't follow the BCLC recommendations that intermediate should go into TACE or systemic. There are some people where even they can be cured, they can be cured with a transplantation by downstaging the disease. And wherever there is multiple nodules are there where we can't resect or transplant, but without any portal vein invasion, definitely we can go for the chemoembolization, either chemo or radioembolization, where there is a diffuse infiltrative and extensive bilobar involvement, where you can't give the test because it will damage the underlying liver and they may not respond well to the TACE therapy. Definitely systemic therapy is the option. So this study, it can be a just single large tumor where we can downstage by doing a TACE or TARE and going for a transplant. Whereas a multinodular disease, again, we can give, TACE can be opted in this without any portal vein invasion. Whereas a diffuse infiltrative disease and the involvement of the bilobar, then definitely systemic therapy is the option. So this is the first one where we can do the downstage the disease and go for the transplantation. So most of them can benefit with a cure. And this is the second one, multinodular with a preserved portal flow, where we can do a TACE or TARE. They have more than 2.5 years of survival. The diffuse infiltrative, definitely systemic therapy. So wherever the patient is like doubtful case for the TACE, don't force them for the TACE because that may be damaging for the liver, underlying liver, and even we may not get the good survival rates. Those patients can be given systemic, because now we have a very good systemic therapies like atezolizumab, durvalumab. So there is no need to be in a hurry to go for a TACE. You can just give the systemic therapy, see the responses, and again you can think about any local regional therapies can be done. So in this, is there any, like, apart from just TACE alone or a systemic therapy alone, can we do combined therapies? So this table showing who are like the early stages, and this stage is the one which will respond very well to the TACE, whereas which is falling beyond up to 7 criteria. Generally we take up to 7 criteria for the TACE, right? So if it is falling beyond more than up to 7 criteria, they are poor responders for the TACE. These are the people where we can think about addition of immunotherapy with the TACE. There is a study with lenvatinib which is shown the survival benefit. It was compared to lenvatinib, not the TACE. The TACE combination compared to the lenvatinib, it has shown the survival benefit, especially in the Asian population and having the viral infection as the etiology. They have shown very good results with combination of TACE and TKI. So this is the study where the people who are not exactly fitting for the TACE, but where you can get benefit with addition of immune checkpoint inhibitors, that is durvalumab, that is Emerald 1 study, combination of durvalumab with TACE. This study has shown the PFS benefits, but not the overall survival benefit. So it is significant, but not the overall survival. So maybe much better studies would be maybe comparing this intermediate stage with just the systemic therapy versus TACE. That may be the better studies, and this will give us much better the decision making results. And you can add again the immunotherapy with a VEGF inhibitor or the TACE. This is like direct comparison of the systemic therapy versus the TACE. So this will give us some more information. So in an intermediate stage, you can go for a transplant. Don't make them into go for either systemic or TACE. You can give the option for the transplant. Think about TACE, think about systemic therapy, think about combination. Whereas coming to the immunotherapy based combinations in this, that is the Emerald study, it has given only the PFS benefit, not the overall survival. Still, we need to wait for it. So there we have completed the advanced stage and the intermediate stage. Now we'll discuss on the early stage disease. See, in the early stage, we know that 20% of them are resectable, and all of them, like most of them will have a recurrence. It can be an early recurrence or a late recurrence. Especially these late recurrences, it can be a second primary tumor or a recurrence, but commonly it can be a second primary tumor. So any other strategies to reduce these recurrence rates? They have tried with the sorafenib in the storm trial, where there is no difference, there is no use of TKI, and the adjuvant immunotherapy like atezobev combination in the adjuvant setting versus the active surveillance. Here the primary endpoint was recurrence free survival. They have taken the high risk disease as a tumor having more than 5 centimeters or a vascular invasion, either a micro or macrovascular invasion, and poorer differentiated tumors. So these are the criteria they have taken for a high risk case. So in these cases, they could demonstrate the recurrence-free survival and the disease-free recurrence. You can see that, but there is no overall survival benefit again. So this is just giving a recurrence-free survival benefit. So we don't know whether these patients, if you followed up later, even if they get recurrence, whether this survival, overall survival benefit, we get it by doing these early interventions, or we trading off for the the late survival benefits with the early benefits. So what is the rationale? So that is the adjuvant setting. We can have immune checkpoint inhibitors where they are giving recurrence-free survival benefit. Can we do a neoadjuvant immunotherapy? Yes, it's feasible. It's investigational right now, and there is no contraindication for a transplant or surgery if you go for immunotherapy as a downstaging methodology. So you can still use a neoadjuvant immunotherapy is possible to reduce the tumor burden, and these are the studies which are showing some responses, complete pathological responses with the perioperative immunotherapies, but these are still investigational. But don't do immunotherapy post transplant. So you can do immunotherapy after resection, that is atezobev, which we have seen, but don't use immunotherapy after transplant, because that will cause the graft loss. So that is not suggested. So what are the options we have? Neoadjuvant, we can try immunotherapies as an investigational procedure where we are able to get the response rates, and definitely they can have an option for the resection or the transplantation. Whereas adjuvant immunotherapy, which we have seen, is the AMBRE 50 study, which has given the recurrence-free survival benefit. These are the other studies going on. So with this early stage disease, what we have learned, atezobev can be used in the high risk resected case of HCC, which is given recurrence-free survival benefit. Neoadjuvant immunotherapy can be tried. It is an area of active investigation, but always think about whether we can downstage the disease and go for a local regional therapies to give a better survival results in intermediate HCC. So to summarize, we have discussed the advanced HCC, where atezobev should be the preferred choice. Durvalumab is also one where they are not eligible for bevacizumab. You can still use durvalumab as an option. And nivo-ep, it has to be get approved, but the study is showing good responses and the survival, median overall survival. And coming to the intermediate HCC, we have multiple options: transplant, TACE, TKI, systemic therapies, and the combination therapies is also an option, where TACE and TKI, especially in the Asian population, has shown the overall survival benefit compared to TKI alone. But the TACE and ICI, immune checkpoint inhibitors versus TACE, it has given PFS benefit. In the high risk early stage HCC, we can see only the PFS benefits. That is, high risk is more than 5 centimeters, or vascular invasion, microvascular invasion, or having a poorly differentiated carcinoma. So in those also you can give adjuvant atezobev, but still only the PFS benefit is there. So with this, I would like to end my talk, and I thank once again for this opportunity.
Thank you, Dr. Chaitanya. I can't find any questions. So I think we'll move on to the next talk, which will be by Dr. Nageshwar from Tirupati, who will be talking about the right selection of patients for immunotherapy. So Dr. Nageshwar, I hope you are there.
Hello, sir.
Yeah, Dr. Nageshwar.
Sir,
You're there?
audible, sir? Yes, sir. Yes, sir.
Yeah, please go ahead with your talk.
Yes, sir, please. Are my slides visible, sir? Hello?
Yes, sir, visible.
Yeah.
Visible, sir, but you need to increase the volume.
One. Hello. Yeah. So, uh, immunotherapy, selection of immunotherapy in its advanced HCC. I think most of the discussion will be is covered by my senior, Dr. Krishna Chaitanya, and then I'll just put main slides. So, we all know that the HCC develops most often in a cirrhotic liver, and cirrhosis might be caused because of various reasons: viral hepatitis, alcohol, alcoholic liver disease, or nowadays more commonly there is increased incidence of non-alcoholic steatohepatitis. And even in the absence of cirrhosis, sometimes hepatitis B infection can directly lead to malignant transformation into hepatocellular carcinoma. And nowadays there is increase in the incidence of hepatitis and then hepatitis related hepatocellular carcinoma and also the NASH, non-alcoholic steatohepatitis, which again leads to the HCC. In India, HCC ranks 11th in the instance and 8th in terms of mortality. That itself indicates that it is a poor prognostic disease, and the incidence is on the rise. And patients who are at higher risk for developing liver cancer can be subjected to screening, which can be done every 6 monthly with a combination of ultrasound and ASP. And most important parameter that decides the prognosis and the selection of the treatment is the Child-Pugh score, which is a combination of 5 different parameters, which includes encephalopathy, ascites, albumin, and INR, and bilirubin. And finally, the patient will be categorized into class A, B, or C. And this is the popular algorithm that we use for treatment of the hepatocellular carcinoma. So, for advanced stages, three things that are important to be checked are: what's the disease-related burden? Is there any portal vein invasion or not? Presence of extrahepatic spread or not? And then how is the liver function as assessed by the Child-Pugh score? And then performance states of the patient. If in presence of any one of these parameter leads to BCLC stage C, and then the main treatment would be systemic therapy with a palliative intent. So, I mean, for almost more than 10 years, sorafenib has been the only option for advanced stage HCC. And from 2018 and 19 onwards, we got the option of adalimumab plus bevacizumab, which was compared to sorafenib. And there are many combinations in advanced HCC which can be tried. Immunocheckpoint inhibitor with anti-VEGF. Anti-VEGF can be either monoclonal antibody in the form of bevacizumab or anti-angiogenic TKI, maybe in the form of cabozantinib or lenvatinib. But again, those are negative trials, as discussed previously. Lenvatinib plus pembrolizumab against the lenvatinib, and cabozantinib with atezolizumab. Both are negative trials, and then dual IO tremelimumab with durvalumab. Again, that's a positive trial. And a brief note on Embryo 150. It was conducted in advanced HCC who were previously untreated, and then the two arms are adalimumab, bevacizumab versus sorafenib, and the primary endpoints are overall survival and progression-free survival. As we can see in the first graph, there is clear-cut differentiation or separation of the two trials from the overall survival, and the primary endpoint of overall survival is met with 19 months with the IVO arm and 13 months in the sorafenib arm with HR hazard ratio of 0.66. I mean, that is like a 34% reduction in the death. Also, there is a clear-cut separation of the curves for progression-free survival, favoring the immunotherapy arm, that is adalimumab plus bevacizumab. And one important thing is the overall response rate of 30% is something unprecedented with a systemic therapy in hepatocellular carcinoma, and that too with 8% complete responses is something very interesting if you take in HCC. And the patient-reported health-related quality of life also favored the combination of atezolizumab plus bevacizumab. And then the comparison of the Himalaya, wherein the tremelimumab plus durvalumab, the stride regimen as famously called, was compared with sorafenib or single agent durvalumab. And the primary endpoint is the overall survival here also. And even in this trial, the dual IO, that is the durvalumab and tremelimumab, has met its primary endpoint of overall survival with 16.4 months versus 13.7 months. And the hazard ratio is 0.78. That is, it led to 22% reduction in the overall survival. But the progression-free survival is similar in both the arms, almost like 3 or more. Even in the updated overall survival, the median overall survival remained the same. So treatment-related adverse effects serious were seen in around 20%, around 17% of the patients in the stride arm. And for the comparison purpose, I have split into three the demographics of the atezolizumab, bevacizumab arm versus stride arm, the efficacy part, and then the safety part. So if you take the demographic data, most of them are similar in the both groups. For example, both the trials included good number of Asian patients. And if it comes to the ECOG performance status, both are equally distributed. And also child per classification. And then BCLC stage C. But one main difference is patients with main portal vein thrombosis, that is VP4, are included in the IMBRAVE 150 arm, but they were excluded from the Himalaya. In many patients with portal vein invasion, those patients, in those patients, the stride arm was not evaluated. And even the hepatitis etiology were also distributed equally. And the prior local therapy was given in 49% of the patients in the AB arm, atezolizumab bevacizumab arm, whereas it was given only 12% of the stride arm. When it comes to the efficacy, and one thing that is really striking is the response rates. 30% of the patients had a partial or complete response versus 20% in the stride arm. If we are doing cross trial comparison, it should be compared with the caution. Maybe we are not comparing the two regimens head on head, but it's a cross trial comparison. And all the limitations of the cross trial comparisons will apply here also. And complete response rate of 8% is something very good. And though numerically, the overall survival is better in the atezolizumab bevacizumab comparatively, and also the hazard ratio is better with the AB arm. For example, it is 0.66 in the AB arm versus 0.78 in the stride arm. And of course, the PFS is same. Between the control arm and the stride arm, control arm, the dual IOM, and the strider regimen. Whereas there is improvement in the PFS with the AB. But when it comes to the safety, AB regimen is a bit lacking behind, with grade 3, grade 4 in the frequency of grade 3, grade 4 adverse effects is 43% versus 26% in the stride. Treatment discontinuation is 22% in the AB arm versus 8.2% stride arm. But however, the patient-reported health-related quality of life is similar in both the in the ABR. So when it comes to the immunotherapy selection indication, maybe as it was correctly pointed out by Dr. Chaitanya, my senior, in the advanced stages, there is overall survival benefit with the immunotherapy, either it is straight or straight regimen or adicilizumab plus bevacizumab. So if you take the early stages, though there is recurrence-free survival improvement with the adicilizumab bevacizumab arm, there is no improvement in the overall. Similarly, in intermediate stages with the TACE combination of immunotherapy, there is improvement in the progression-free survival, but there is no improvement in the overall survival. And then other point to be taken into account is liver disease. Usually most of the patients which are included in the trial are child-pug A, but most often we do get patients which belong to child-pug B also. Maybe if it is because even in the child-pug B there are different categories. If it is because of a bit of low albumin or ascites, which can be again attributed to the liver disease itself or disease-related disease, we can give a try of immunotherapy. So, though the trial has included mainly child-pug A, even if it is child-pug B 7 or 8, we can still try the immunotherapy. As I'll put a real-world data which is given in the next slide. And then performance status. Maybe performance status is one other factor which needs to be considered. Like 3 or 4 performance status, we can try immunotherapy, or for that matter, any comorbidities and autoimmune disease. These are the things which also taken into important. For example, active inflammatory bowel disease or autoimmune hepatitis or Sjogren's disease or SLE. This we can't use immunotherapy upfront in these cases, or for that matter, we can't. Those are contraindicated. On the other hand, if there is mild hypothyroidism or type 1 diabetes or dermatological conditions like eczema, psoriasis, if they are well controlled and if they are mild, immunotherapy can be still tried even in these autoimmune diseases. And we need to check whether there are any contraindications to bevacizumab or not. So as HCC develops in patients with cirrhosis, they are the patients who have varices or variceal bleeding. Before going ahead with IMBRAVE 150 protocol, we need to rule out all the varices. If there are higher grade varices, they should be banded. And we need to rule out the other bevacizumab contraindications like recent hemorrhagic stroke or MI, and if there should not be any active bleeding, all those things, or uncontrolled hypertension for that matter. And then regimen. Maybe if in a patient where the symptoms are attributed to the disease as such, maybe we can use a regimen which has higher response rates, such as adicilizumab bevacizumab. And post-transplant, as indicated by Chaitanya sir, immunotherapy should not be used in those patients who already underwent any transplant or liver transplant or any other transplant, because in those patients who underwent liver transplant followed by immunotherapy, the rejection rates are 30 to 50%. But immunotherapy can be tried prior to the transplant as a modality to downstage the disease. That is okay, but not immunotherapy after transplant. And this is one real world data. I think Sir Vamshi Krishna sir is also one of the co-authors for this. And though immunotherapy has been tried in child-pug B or C, the survivals are better with the child-pug A, as one could expect. So in the second line therapy, we have many options: regorafenib, cabozantinib, ramucirumab, and we have also pembrolizumab or nivolumab or ipilimumab. There is no single agent that can be told after that, yeah, this is the regimen to be used. It all depends on the prior treatment, performance of the patient, and suitability of the particular regimen. And as per the NCCN guidelines, both shares the category 1 recommendation, the adicilizumab bevacizumab arm and tremelimumab durvalumab. And see, atezolizumab, bevacizumab, and durvalumab plus tremelimumab are category 1 first-line systemic options. Choice based on individual patient comorbidity and risk factors like varices, cardiovascular disease, autoimmune disease, and patient preferences should be taken into account. TKIs such as lenvatinib and sorafenib or single-agent durvalumab are first-line options in patients with, who are eligible, not eligible for immune checkpoint immunotherapy or combination therapy. And second-line options include TKIs, pembrolizumab, and dual IO, nivolumab with ipilimumab. And choice should be guided by first-line treatment and response and toxicity. No prospective or head-on comparisons among the second-line treatment options. Only subset of patients who experience deep and durable responses with frontline immune checkpoint inhibitor-based combinations, there remains a great need for further advancement. This is the end of my talk. I again thanks the organizers for giving this opportunity. Thank you.
Thank you, Dr. Krishna. I think we are going to be discussing all these issues in the panel discussion as well as to who will decide which immuno to be used and which are the right patients for immuno and how you'll manage the complications. So thank you again very much. Next, we have Dr. Sharat Chandra, who will be talking on a probably less glamorous topic of TKIs in HCC today. So Dr. Sharat, over to you.
Hello.
Yeah, Dr. Sharat, can hear you.
Good evening, sir. Thank you for this opportunity, sir. And also I thank Rosh again for this opportunity. So can I just share my screen once?
Okay. Patient treatment condition.
So I've been given this topic of TKS in HCC Indian perspective. So as Vamshi sir rightly pointed out, the less glamorous topic in the world of immune checkpoint inhibitors in HCC. So we all know that HCC includes both definitely the cancer to be dealt with and also the bad liver, which we are also dealing with because many of our patients have, majority of our patients have coexisting cirrhosis. So there is loss of normal architecture and microcirculation, reduced hepatocyte mass and function and all leading to portal hypertension and reduced liver function reserve and also reduced hypertrophic response. So this is what we deal with cirrhotic HCC patients. So the impact of this liver decompensation on patient survival is well documented in terms of treatment. So as nicely pointed out here in terms of Kaplan-Meier curves, if you have compensated cirrhosis, the probability of survival is definitely much higher than in a patient with decompensated cirrhosis. So that is one factor which will definitely decide how the survival is going to be in terms of treatment of HCCs. So as we go forward, I mean, the initial days we had response rates from doxorubicin, and then those were initially documented in a very limited set of patients in a phase 2 trial where the response rates were there with patients living till roughly a year with adrimethrin 75 mg per meter square 3 weekly. And then that was also used in inoperable HCCs with very minimal responses. And from there came the sorafenib with the SHARP trial. So initial days, we only had doxorubicin and now a barrage of different therapies. So this is a timeline. So as we could see initially, in the first line, sorafenib was the drug which was approved apart from other limited chemotherapies which we had. So 2007 was the time when a SHARP trial came and the response rates and HCCs giving us the response rates of around 30 to 40% and patients living till a year or more. And then post that from 2017, I think there were many more approvals in the first line and second lines with the immunotherapies pitching in the second line to begin with and then pushed to first line and then taken over by them from the TKIs. So roughly, this is the treatment chart which we generally follow, the BCLC staging and the treatment strategies for hepatocellular carcinoma, to briefly point out, in very early stage, we see if a potential candidate for liver transplantation and go ahead. Otherwise, we try and ablate. Then in early stage, depending on the sizes and the liver functions, we see if a resection could be done, or if it is contraindicated, we try and see if we could ablate. And then depending on the sizes and the liver transplant criteria, one could offer that also. In intermediate stage, it is mostly TACE unless you have a desirable situation for transplant. Even in intermediate stage, if you have a diffuse infiltrative and bilobar involvement, we try and get patients away from TACE and offer systemic treatments only. And in majority of our advanced stages C, we try and offer systemic treatments with the options from immunotherapies, which were just discussed in the previous two talks. And I'll be discussing a little more about the other options, which are TKs and other combinations of TKs plus TACE in the first line and second line. In terminal stage D, definitely we just offer best supportive care. So this transition from early BCLCC, BCLCB to extensive, and then BCLCC in terms of vascular invasion and other extensive stage, we switch from local regional therapies to systemic therapies depending on patient to patient basis and also case to case basis. We'll also discuss a little about our TACE plus lenvatinib and TKI combination a little, and where we can put in that particular regimen. So the treatment options definitely for first line, I think that Atizo plus Bev is always there. Then we have recently durvalumab and tremelimumab combinations coming up. We also have data for individual anti-PD-1, pembrolizumab and other therapies in first line. We have lenvatinib and sorafenib data also in first line, and then in second line, it is largely cabozantinib and regorafenib, which we generally use. But these trials came in the pre-immuno era. So majority had progressed after first line sorafenib, and then these trials were applicable. We also have data for ramucirumab in the second line. So the initial data definitely came from SHARP trial, which used sorafenib as the first line TK and compared with placebo, giving us a median OS of around 3 months, around 3 months improvement with hazard ratios of 0.69. Then the same trial in the Asia Pacific population also had fared definitely well, but not as good as the West. In the Asian population, definitely the OS was around 6.5 months in favor of sorafenib when compared to 4.2 months with placebo, giving us a hazard ratios of around 0.68. So we had data for sorafenib first line across different patient populations, geographic regions, and then this quickly became our standard of care into the 2007, 2008, and 10. Then going into the second decade, so this particular trial gave data for lenvatinib as a first line option, and it was directly compared with sorafenib, which was the standard of care back then. So this is an open label non-inferiority phase 3 trial which compared lenvatinib as a first line option to sorafenib, and that gave us a marginal improvement in OS. Marginal improvement in terms of numbers and the hazard ratios of 0.92, which said that it is definitely non-inferior, but a little higher progression-free survivals when compared to sorafenib, from 3.7 months with sorafenib to around doubling, almost 7.4 months with lenvatinib. But the OS was definitely not there, maybe because of a lot of crossover. This was one more agent which got approved in first line, both in child gay or your BCLC stage B or C. So then came your barrage of immunotherapy trial data. I think it was nicely discussed in the previous two sessions. I am Brave is what gives us the best hazard ratios. And then we also have Himalaya data. And then we just discussed one lenvatinib versus sorafenib combinations. And then is again checkmate 459, which compared nivo to sorafenib with hazard ratios of around 0.85. So these are all your first line available therapies apart from sorafenib. So the one more thing to discuss in first line is whether your HCCs, which are non-viral related, which is NASH related, do they do equally well like your HBV, HCC related hepatocellular carcinomas? If we go back to IM Brave subgroup analysis, we could see that a little around 25% of patients had non-viral HCC, and the hazard ratios of that particular subgroup is 0.91, completely different from the HBV, HCV hazard ratios, which are sitting nicely at 0.51 and 0.43. So this initially gave us an indication that maybe the viral subgroups do very well with your immune checkpoint inhibitors when compared to non-viral HCCs, but this is just a subgroup analysis. And then also, the NASH limits anti-tumor surveillance in immunotherapy treated HCC. This is a meta-analysis which check this particular point again with your checkmate 459, IMBREW 150, and Keynote 240 trials. Even that particular meta-analysis said that immunotherapy improved OS in the overall population and in viral HCC, but not necessarily in non-viral HCC. So this is one data set where immunotherapy may not do as good as the viral population. So, again, to reiterate this particular point, we have real world data also. This is one particular data set which evaluated survival outcomes in patients with non-viral HCCs treated with immunotherapy versus your TKS. So this is a data set of retrospective data of prospectively collected BCLC stage B or C patients who were either treated with atezo plus bev or lenvatinib or sorafenib as first line treatments for advanced non-viral HCC, and then they compared which one is better. As you could see, in terms of both the PFS and OS, definitely the TKS did much better when compared to our atezo plus bev combination. If you had a non-viral HCC to begin with, almost the OS of lenvatinib was close to 21 months when compared to 12 months, which are hazard ratios of 0.46. Then again, this is just retrospective data. Even the PFS was definitely in favor of TKS when compared to immunotherapy plus bev combination. This is one data set where you have to be wary of using immunotherapy combinations. So then optimal sequencing in second line, we have data from these three particular trials, although all these trials were performed in the pre-immunotherapy era. So they all had patients who had progressed on first line sorafenib, and so whether these are applicable to present scenarios is what we would discuss, because many of our patients definitely would either go on to receive lenvatinib or atezo-bev combination, if not sorafenib. So the applicability of this needs to be also discussed again. So, but regardless of that, we have data of regorafenib from resource trial. It is giving us the hazard ratios of around 0.63 in terms of OS with 2.6 months advantage when compared to placebo post your sorafenib progression. Celestial is one trial which compared cabozantinib to placebo. Again, it could be either in the second line or third line. OS of around 2 months benefit, hazard ratios of 0.76. And then again, reach 2 is compared ramucirumab to placebo. This had to have an AFP of more than 400 as an eligibility criteria, and this is also in the second line with the median improvement in OS with the hazard ratios of 0.71. So all these three data sets are there in second line posterior sorafenib progressions. So how do you choose a second line agent? Is you have to have a first line usage of sorafenib if you want a proper data applicability in present day. So that is how they did in these particular second line trials. So then again, what else apart from just TKS or immuno combinations? So space trial is one trial which added sorafenib to TACE in BCLC stage B HCCs. So the time to progressions was not much different, and then it did not translate into a good OS survival. So this never translated into a good approval. So this is regardless of that, this is one trial which could be discussed if what else could be done apart from just TKS or immuno combination. So sorafenib plus TACE. Then again, this is one trial from China, which was recently discussed in 2022 ASCO. So launch trial where they had actually used child Puget patients and BCLC stage C and not B. So majority of their patients were BCLC stage C, where they had used lenvatinib plus TACE when compared to only lenvatinib in advanced HCC, and then they went on to demonstrate a good improvement in OS when compared to only lenvatinib, numerically increasing by about 6 months. So with the hazard ratios of 0.45, even the PFS was much better when compared to only lenvatinib. The overall response rates were also definitely higher. But the downside is the grade 3-4 events were much higher in the lenvatinib plus TACE arm when compared to only lenvatinib, and there was much heated discussions about the applicability of this particular regimen into the actual world, because this data had only come from a Chinese population. So then the ongoing phase 3 HCC trials with TACE combinations are just shown here. So we have TACE plus durvalumab versus the other combinations, and in LEAP trial it is lenvatinib plus pembro plus TACE versus TACE plus placebo. So in future in the next 1 or 2 years, maybe we could hear good data coming from these particular trials. Also, whether this particular sorafenib is applicable to an early stage HCC, so systemic therapy is generally not recommended outside of metastatic disease or a disease that is not amenable to local regional treatment. So regardless of that, we have data from STORM, a trial where it is a phase 3 study that compared sorafenib versus placebo as adjuvant therapy for patients who underwent hepatic resection or ablation with curative intent. Definitely, the sorafenib was poorly tolerated and did not translate into any significant benefit in terms of OS or recurrence-free survivals or time to recurrence. So this was this thing from STORM trial. So what about treatment of advanced HCC in India? We all have our unique challenges in spite of good data sets coming from the West. The applicability is definitely a question. So it all boils down to or translates to our financial this thing. So a nice Indian map is shown here, where the percentage of patients who are in poor segment is all shown here. Definitely in our state around 13.7%. I think it is much higher than that when compared if we see about the applicability of immune checkpoint inhibitors in HCC. So then again, the advanced HCC data coming from applicability of sorafenib in the real world. So you could see that sorafenib therapy was well tolerated and provided about 3 months longer OS in even our patients than when treated with BSC alone. But then the side effect profile of in Indians is definitely much different than the West. So this again a data set coming from Indian authors. So tolerance and adverse event profile with sorafenib in Indian patients, as you could see, the significant proportion of patients had cessation of sorafenib due to adverse events, which is definitely different or from the West. So again, how we could better this is a phase 1 study also evaluated a dose de-escalation from 800 to maybe 600 of sorafenib with addition of metformin and atorvastatin. They said the side effects were better tolerable with this strategy, and you could reduce from 800 to 600. But this is just a phase 1 data set. So then again, multidisciplinary care is what is needed for HCC. With different conferences and other multidisciplinary these things improving our survivals or our early detections and everything in terms of HCC. So TKI definitely would continue to remain mainstay in our country. Survival with sorafenib has increased definitely over a period of time from 10 to recent trials showing close to around 13 months of PFS. So sorafenib continues to remain the comparator arm in majority of studies even now. Dose modification studies are also important. Lenvatinib again remains a robust option in first line. Cabozantinib and regorafenib remain our option for second line and subsequent lines, those who have progressed on maybe sorafenib, but then we also use this even after lenvatinib. So out of pocket country, TK is easily available in our country. Majority of our patients go on to use only this in HCCs. And then we also need to build our own data to answer our own problems is what the point to be noted. So thank you.
Thank you, Dr. Sharath. It was a very nice presentation of the role of TKIs, and I agree that a lot of our patients still go on TKI because of the cost issues. So that is always there. So the next talk will be by Dr. Sujana, who will be talking about role of SBRT in HCC. And as she likes to keep saying in my department, I believe in radiation more than even the radiation oncology. So over to you, Dr. Sujana, for elucidating the best place and the setting for SBRT.
Yeah, thank you, Dr. Vamshi, for a kind intro. And I will share my screen. So can you see my slides?
Yes, ma'am.
Yeah, okay. Very good evening, everyone. I know that it's late and I'm not going to take much of your time. So I will probably Dr. Vamshi has mentioned that I'll be talking about the role of SBRT in HCC. So I've just changed the title a bit by kind of calling it "How do we identify an ideal candidate for SBRT?" because that is most important. So in the era of local treatment, like liver-directed treatments, I think so everyone should be knowing as to what an ideal candidate should be for liver-directed or local treatments. So my flow of presentation, I'm not going to in detail go into the BCLC staging because my previous speakers have already spoken about it in detail. I'll probably talk about the trials comparing several liver-directed treatments versus SBRT and also the MDT-based process flow. I will discuss this with a clinical case. And I would also like to emphasize on the post-SBRT imaging and a few upcoming trials and evidence comparing different modalities. And so, like I said, I'm not going to go into the BCLC part of it. We already know what the BCLC has to say. I'll straight away jump into the different modalities and its importance and its comparison with SBRT. So if you look at the retrospective SEER data, because RFA has been there in the market for a very, very long time. If you actually historically look at it, SBRT came as a liver-directed treatment very late in the whole armamentarium of treating liver malignancies. So the reason being, so we actually got IMRT like around 2000s probably, and we started using a bit late in the clinic. And slowly after that, we slowly started getting into SBRT. And by that time, RFA has already been established in the armamentarium of managing HCCs. So even though it's not being used predominantly because of the fact that the frequencies of what RFA we use is probably not sufficient to completely ablate the tumor. And one more important criteria, because the periphery doesn't get adequate dose with all the frequency of radio frequencies what we see. So these days, most of the clinics in the around the world have shifted to microwave ablation. And if you look at this data, if you don't look at closely, but if you just look at the curves, so it appears as if RFA has definitely fared well compared to SBRT. So if you look at this data again at a very, very granular level, there is no lack of granular level propensity score matching, and there is no account for hepatic dysfunction. And there is also failure to account for subsequent locoregional treatment. This is a thing of the past. This has been published way back in 2018 because they wanted to pool all the patients. But still 25% of SBRT patients in this had low or very unknown radiation dose, which is probably not acceptable in this day and age. And if you look at the SEER data about the cost effectiveness, there is no difference in the 90-day hospitalization, and there is no difference in the overall cost effectiveness. And at the same time, size definitely matters. If your size of the lesion is more than 2 centimeters, definitely SBRT fares well. So if you look at the comparison between SBRT versus RFA, there is no strong evidence, but most of the evidence is derived from a lot of retrospective data. So the meta-analysis of all these papers show that the local progression of that local control is definitely better with SBRT, and if the size is more than 2 to 3 centimeters, SBRT has a definite role because it encompasses the tumor with a homogeneous dose, and which is unfortunately not done by RFA or other modalities. The overall survival at 2 years looks comparatively better with RFA, but because of the tumor burden or liver profiles, so well-designed randomized trials we don't have as yet. So, but if you look at the older guidelines like 2022, 2023, and even the latest 2024 guidelines, external beam radiotherapy has gotten a place in the most popular NCCN guidelines, which most of us usually follow. So, if you look at other guidelines also, so but as I said, the first preference is because of local ablative therapies. The reason being it has been in this space for a very, very long time. So of course, order does not indicate preference. Choice of modality depends on a lot of things: patient preferences, hepatic reserve, the size of the lesion, and institutional capabilities to carry out these kind of high-end treatments. So we have already got comprehensive guidelines, clinical practice guidelines. There are Korean guidelines, Japanese guidelines, and everything. So previously back in the day, we used to we were discounting all the patients of PCLCC in the sense patients with MVI, macrovascular invasion, we were completely discounting. But after the publication of RTOG 1112 and a lot of other retrospective and prospective evidences, we actually started, we stopped discounting them. We started treating aggressively with local treatments and subsequently pushing them for maintenance systemic treatments. So if you just quickly look at the pre-SBRT checklist, you first have to look at the performance status, your routine bloods, LFTs, AFP, CPS score, and imaging. Especially MRI is preferable. Please don't rely on a PET CT because MRI is supposed to be more sensitive in picking up smaller lesions and also to rule out extrahepatic disease. So I'll just quickly present a small case scenario which we have treated in our clinic. So in March 2021, we have treated a 45-year-old male with an alcoholic cirrhotic liver with CLD who presented with generalized pain, and he was diagnosed to have small HCC. So this is the MRI image. There's a very small, very nicely well-defined lesion in segment 6, and also there is a small portal tumor thrombus. So it is a TIV lesion, and because it is a TIV lesion, automatically surgery has been ruled out. It's basically a BCLCC. So surgery we have ruled out because of the size and also the tumor in when we've ruled out RFA and microwave ablation. TACE is a contraindication, and TARE, because of the financial constraints, they were not able to kind of go ahead with that. So we've just left with SBRT. So this is what we have done. We have nicely contoured and we have treated the whole tumor as well as the parenchymal and extraparenchymal vascular disease also. So we gave a very good dose of 50 grain 5 fractions. We've used some high-tech technology called a DIBH. I think most of the centers in Hyderabad are capable of doing this. But the precision as to how a threshold has to be set has to be mastered before we go ahead and do a real-time positioning management of these kind of patients. So a review has been done after 10 weeks. There were no associated complaints. Patient is doing well. Interim, we started him on after 2 to 3 weeks of radiation. The patient has been started on lenvatinib, but he was completely non-compliant. So if you look at the comparison of lab parameters, his initial AFP was 1530, and after that it came down to 7.9, which has shown predominant change and a very, very good response. So if you look at the PET scan and the MIP image of the PET scan, there is a definite response. The complete tumor thrombus has completely faded away. And as on MRI also, so we have done an MRI, we have almost given a gap of around 4 to 5 months before we kind of called it a very good response. So there's complete resolution. So again, I'm not going to completely emphasize on BCLC guidelines, but even though back in the day they used to just say either leave the patient if the performance is bad or push the patient for systemic treatment, I think we are heading more and more on the lines of local treatments with radiation, TACE or TARE, along with systemic treatments. That is what we are heading these days. So when do we decide and what are the indications for SBRT? Technically, the patient has to be child A, and up to child B7, we can relax our constraints a bit, but not beyond B7. Performance is one important criteria. And BCLC-C is typically a lot of things have been put under BCLC-C, but only portal vein invasion of BCLC-C is permitted. BCLC-C also, extrahepatic disease is also called BCLC-C, but that part is not included. So maximum tumor dimension should be less than 10 centimeters, and other important criteria is more than 700 cc of normal liver should be spared. There should be no other extra-abdominal or extrahepatic mets, no history of prior radiotherapy, and no concomitant systemic therapy, and absolutely no. So contraindications, patients with child B7 is obviously a contraindication. Intractable ascites, because the patient is obviously going to is already decompensated. And active viral hepatitis, the reason being you have a lot of inflammation already, and if you try to induce a lot of inflammation, it will be a problem. History of hepatic decompensation, platelet count less than 50,000, because the patients are bound to bleed just in case if there is any vessel close by. And luminal GI structure should be away at least about more than 5 millimeter. If it's less than 5 millimeter, it's an absolute contraindication. So there have been a lot of data coming from different parts of the world, a comparison between radiotherapy with portal vein tumor thrombus. So there've been a lot of articles and a lot of data being published, because back in the day we were kind of discounting, like I said. But anyhow, so we have already finished SBRT part. So what is an ideal time to do post SBRT imaging? That is a very tricky thing, because patient usually comes back and asks us, so doctor, what is the response of treatment? We've taken a lot of pains, and what is the response of the treatment? So especially when you're looking at the post SBRT image, you have to look at two specific components very specifically. One is the tumor part and one is the normal liver. So the reason being, you have not only irradiated the tumor, you have irradiated a part of the normal liver also, because of the margins and because of the movement and everything. So, and why do we need response evaluation? If your intention is bridge, for example, if the patient is going eventually for a transplant, if your intention is bridge, then you have to know the essential tumor burden to kind of have a discussion with your surgeon. And also it enables a clear communication between different specialists. And for example, if there is any other lesion, because CLD is a big base of inflammatory liver is what you see in CLDs. So there might be some other non-specific, some small tumors elsewhere in the liver which might be cropping up because of the inflammatory bed. So also you need to inform the patient, you need to have a clear decision making while talking to the patient. And also you have to make sure whether you need a retreatment about other lesions, and whether you are justified in pushing the patient for local treatments or transplant. So the exact timing of evaluation is not very clear in literature, but the logic guidance is usually the best is to do at 1 year. 6 to 9 months is also an acceptable alternative, but not less than 3 months, because there'll still be a lot of inflammation, and the radiologist will not be able to categorically tell what exactly is the response. So the imaging criteria is similar to the baseline diagnostic criteria, APHV, washout, and the size. But here I would like to make a point that size is not all what we see, because there might be an increase in necrotic component, which will probably translate an increase in size. And if you go by the risk criteria, you might call it as a progressive disease. That's not how it works here. So here the keyword is the enhancement, enhancement, and enhancement. So if you have a persistent APHE and there is still rim enhancement, and you call it whenever you're going to call it LRTR viable because of enhancement, you better put in a needle and then kind of cross check before you call it. So this patient is a real patient. The radiologist called it an LRTR viable, but the histology wise it is non-viable and necrotic. Again, if you look at the different image criteria at baseline, if you see how the tumor looks, and at 3 months you can definitely appreciate the reduction in the enhancing component and then increase in necrotic component, and slowly at 6 months and 9 months the reduction in enhancing component becomes more pronounced. So RECIST is probably not a very good parameter to assess, especially with respect if you're calculating the whole size. In RECIST criteria also, you have to calculate only the enhancement component and leave out the entire tumor. So these are a few examples. So this enhancement is nothing but post TACE. This also looks very hyperdense and very enhancing. So these are all the DEB beads in the residual liver. So this is how the pre-treatment washout looks. This is an LRTR equivocal, and this is non-viable. So to summarize, it is very important to assess the treatment response and always use a LIRADS treatment response algorithm whenever you try to assess the treatment response. So it's already been hot off the press for a very, very long time, and we have been cheering for RTOG 1112 for a very long time because of the results. So anyhow, I'm not really going, because every one of you who are sitting here are aware of the 1112 results. So it's really shown OS, PFS, and time to progression. So this is one more trendy trial. Of course, it's again a comparison between TACE versus SBRT, but it's unfortunately closed early. But definitely there is a trend for better trend for improvement in local control in the SBRT arm. But of course, we cannot take this by face value because it's closed early because of lack of approval. So there is definitely a paucity of RCTs and good evidence. For now, the only good RCT evidence what we have is from RTOG 1112. So again, if you look at the TACE and the TARE, so of course, like I said, there is a problem with TACE, and sometimes to kind of lean on to, I mean, if you don't have capability to kind of do SBRT in your system, sometimes we lean on and get go ahead and do a TARE. But in the Indian context, the problem is the cost. The TARE is very, very expensive, and not all centers are capable of performing these kind of high-end treatments. So again, this is a different trial comparing TACE with DEBOX versus SBRT as a bridge to transplant. So this is one of important papers published by El Sapir, one of the great. This is a retrospective study, and showing that there is more than 4 times better local control with SBRT compared to TACE. So there is in the future, there is an interesting signal for IO-SBRT combination. We all know about the abscopal effect, so I'm really not going to go there. So even though it's not been proven, but a lot of times we kind of advocate for this kind of IO-SBRT. We keep doing that at our institute in a very, predominantly we do that because of our capabilities in performing a lot of HCC cases. And this is one more Comito phase 3 trial. And if you, the question what this specific trial is, if you fail one round of TACE, are you justified in going for one more round of TACEs? That is the question this trial kind of tried to answer. But the local control definitely tanks 7-fold if you kind of repeat TACE again. So if a patient fails TACE, you don't have to kind of tell the patient there is no option available. You can definitely send for SBRT, because the question of TACE is different from TARE. In TARE, again, you give the radiation beads and all, probably will be a bit hesitant to take him up again. But that's not the case with TACE. If you're not able to achieve a good local control, definitely we are there. So why are we so confident? Because of the BEDs of what we'll be able to achieve with 100% certainty to the 100% of volume. So that is our go-to mantra. So that is the reason we're very, very confident about SBRT. So all patients should be counseled on the truth as far as we know it. And if you look at other modalities like microwave, TACE, and TARE, the local control of what SBRT is going to give is not even close. Of course, like I said, we are all radiation oncologists. I think we cheer for and champion for a local control than the OS benefit, because you're all medical oncologists. You have a different thought process. But in patients without macrovascular invasion, I suspect MVI will definitely tell a different story. To conclude, SBRT is new, definitely new, but the data is definitely encouraging with respect to local control. Without any RCTs, any rigid stance is probably a bit dogmatic. Lack of RCTs, but robust phase 2 and retrospective data is there. The only one quick RCT I can recall is, like I said, the Laura Dawson paper, and it is definitely preferred for large subcapsular and perivascular tumors. Any liver directed treatment has got its own contraindications, so you basically have to pick and choose. Case selection and MDT based discussion is the key, and synergy with IO is the future of what we are looking at. So thank you so much for your patient hearing. I'll be happy to take any questions if you have. Thank you.
Thank you, Dr. Srina. I think that was a very, very nice lecture that you gave on the SBRT. Of course, this is what we routinely talk and discuss about in the tumor board. So we are we are very used to this thing. So I think the next moderation panel will have some involvement of the radiation. So probably that's where the panelists are going to discuss about role of RT and so on. So what I'll do is I'll start off my presentation, which is going to be on the role of okay, just a second. How do I share in this? Yeah. So will be a panel discussion on advanced HCC. So I will just call my panelists. Dr. Srinath Bhardwaj, are you there? Srinath?
Yes, sir, I'm there.
Okay, great. Dr. Srinath, then Dr. Rekha.
Yes, I'm here, sir.
Dr. Vishal from Hyderabad. Dr. Vishal? Okay, Dr. Shravan, I could
Yes,
see
sir.
you.
Hi.
Hi, saw you. And Dr. Ram Prahlad from Guntur.
Yes, sir, I'm there.
Okay, so we don't have Dr. Vishal. So Dinesh, if you could just call him and see if he's around. Otherwise, we'll just go ahead with the rest of the speakers. Right. So I hope my slides are visible.
Yes, sir.
Okay, perfect. So I'll just do a small case. Now, this is a 56-year-old male, a known case of CLD, HBsAg positive. He presented with abdomen pain, CT scan showing large liver lesion, multiple other lesions in the other lobe, then multiple pre-caval and portal nodes. So clearly large, well-defined nodes. This is a metastatic disease. So he came with a high AFP of 35,710. Endoscopy only showing grade 1 varices. So let me start off with Dr. Rekha. Anything else you want to decide on your treatment? No major comorbidity, CLD, HBsAg, and this is the presentation. So what next?
CPS calculation.
CPS would be A5.
Yes, sir. Then that's it.
Okay.
I mean, the basic panel before we start the immunotherapy, the endocrinal.
Absolutely. I think that's the standard one which you would do. Okay. So, Dr. Rampralad, anything else that you would like to check?
We can do a PET CT scan also.
For looking for? I mean, do you think
for the aggressiveness of the tumor?
How will PET scan show the aggressiveness?
By the SUV uptake, like.
No, there is. I am not aware of any data that says that the SUV correlates with aggressiveness in any tumor. I am not sure if any of the other panelists would have any experience on this. But SUV is extremely subjective. So I don't think an SUV in any other situation other than a lymphoma where you're looking at the dual score really makes a difference. So, Srinath, your thoughts on that? Dr.
Sir, no,
Srinath?
sir, I wouldn't do a PET, sir. I'm happy with the triphasic CT and I'll keep monitoring you the triphasic CT.
Okay.
Grade 1 viruses, so I'm okay with giving bevacizumab, of course.
Okay.
But any grade other than that really scares me.
Okay, fine. Dr. Shravan?
Same here, sir. I would like to check the HPV viral load also once prior to
I was
therapy.
looking for that. So this general thing, any patient with a HPSAG which has been adequately on treatment, you could probably not need to wait for it, but it would be a good idea to check the HBV viral DNA load at baseline. So that's a standard we do for everyone, and again, involve the hepatologist in the management. So typically there's always a discussion as to when you want to start the treatment if the patient is untreated. So what's the normal practice, Dr. Rekha? Patient has come newly diagnosed as HBsAg, not like this, but newly diagnosed, has a high viral load, say log 5. Would you start the treatment after some time, immediately? How do you go about it?
So, I guess we could start at the same time, sir. I mean,
Yes.
as soon as the
Okay.
treatment is instituted, we
Okay.
can.
Dr. Ram?
We have to treat the patient at least for a month or so that
Yeah.
the viral load will decrease.
Okay. So again, there is
Because there will be a clear.
actually no real huge level 3 evidence for this, but in general, people wait for 10 to 15 days. We tend to wait for 2 weeks till the viral load settles if the patient is previously untreated. Like I said, if patient is on treatment, it doesn't matter. But if patient is not being treated or newly diagnosed and has a high viral load, it's always better to wait because your chance of hepatitis does go up significantly if you start the treatment. Okay, so let's start off with the possibly most important discussion today. You have the Himalaya Stride Protocol, you have the IMBRAVE 150 Atizobev, you have the Checkmate 9DW, and you still have a lenvatinib, as Dr. Sharath pointed out, that it is still used in a lot of patients. Assuming no financial issues, Srinath, what would be your choice?
The highest experience have been with Atizobev, sir, but I think the other options come into play, especially when there is varicose bleeding. Because, I mean, the extent of cirrhosis and CLD is a big concern in HCC cases, especially in India, in the late stage when we see them. Apart from varicose bleeding, I'm still comfortable right now with Atizobev because of the extensive experience. But other options I would definitely consider when there is significant varicose bleeding or anything of that sort.
So again, extensive experience of yours, what is the general number of patients who who have a variceal bleed at presentation or who have, urgently requiring any banding or anything like that in
My
HCC?
experience has been extremely bad with HCC, sir. Every patient of mine had variceal bleeding and I couldn't start BEV at upfront. I had to wait. Few patients had to wait till the bleeding. They did multiple bandings and I had to ultimately put them on lenvatinib. So now if we have Nivo-IP and tremelimumab and durvalumab doing the job for us, I think that would be alternative to lenvatinib.
But we have, I think I don't remember more than 2 or 3 patients in the last couple of months, we had to actually not give BEV. Most patients do not have any active viral disease. I mean,
yes, sir, that's what my luck has been bad, sir. That's
I guess that's what. So, Dr. Rampralad, your thought, your plan between these three, what would you, or between these four? Let's assume finances are not a concern. That's taken for
Yeah,
granted.
I would prefer the Atizobev and Bev in view of HBsAg positive nature. So, space.
Okay. Is there any data that Stride won't work there or Checkmate will not work in a HBsAg positive?
No, not that. But the response will be very fast in case of Atizobev when compared to Himalaya trial.
On what basis is that statement? I mean, because the Himalaya is similar.
Both are immunotherapy drugs in the Himalaya, so the response will be a little bit delayed when compared to IMBRAVE, where the bevacizumab as a anti-VEGF will have a little bit better action.
I'm not aware of this data because honestly, there is no such thing to say the anti-VEGF acts faster because in colon you don't see it acting anywhere. So I'm not sure if that's the right explanation for this. So again, my doubt to you is like, otherwise, what makes you decide between these three regimens other than the variceal bleed, which Srinath has already spoken about? So Dr. Ram, anything else that will make you decide between these three?
Mostly variceal bleed will be deciding.
Variceal bleed will be deciding. So again, interestingly, if you look at the clear data, lenvatinib itself had a history of variceal bleeds of around 3%, whereas Atizobev had it around 4% in their study. So it's not that lenvatinib really doesn't cause any variceal bleed at all. So that's one interesting thing which, and lenvatinib is again one of the, anti-VEGF also it has its action as. So again, next thing, Dr. Shravan, your thoughts on this? What would you choose and on what basis?
Sir, the only consideration was the possibility of a varicose bleed because this patient is already a CLD patient, chronic hepatitis B. So probability of his grade 1 varices progressing is higher. So if given a chance, I would like to do Himalaya protocol, stride protocol, compared to Etizolam.
So, the reverse question, what I asked Srinath, how many patients will not have at least a grade 1 virus in HCC? I mean,
Yeah, but
almost 90% are going to have a HCC grade 1 virus at least. So you want to stop giving Etizolam to all of them because there's a possibility of progression to varicose bleed.
no, sir, because the viral induced CLD, always they do bad. That is what I feel.
Bad with Etizolam?
No. In terms of progression of CLD.
Okay.
So they have higher chances of developing grade 2, grade 3 viruses.
As far as I'm aware, there's no such data existing that says that if you have a viral disease, the incidence of viruses go on. I'm not aware of anything like that. Dr. Rekha, your thoughts between the three?
I'm comfortable with Etizolam, sir, mostly because I'm more used to it. I have used it and data is there. So
okay, so data is there for Himalaya as well. The STRIDE protocol actually has similar kind of OS advantage. I won't say same, but similar kind of OS advantage. The highest advantage is actually the Checkmate 90W. In fact, this ESMO Asia, they have presented the 90W cohort of the Asian subpopulation. And the benefit of OS there is 32 months, which is pretty much unprecedented across every drug that you see. So, 90W is there. So again, Dr. Srinath, your thoughts. I mean, you said Etizolam because you're used to it, but what is preventing you from using STRIDE in even a normal cirrhotic patient with a HCC metastatic?
Yes, I think when you see the confidence interval,
it's almost the same. Confidence intervals are almost the same. There is hardly any difference between the two. The difference is that will be that those patients who have Etizolam, the trial showed a PFS and an OS advantage, whereas the Himalaya did not show a PFS advantage. It showed only an OS advantage. And the 90W has shown both. The 90W for me, the biggest challenge is the dosing. This is not a N3I1. This is N1I3, which means 3 milligram per kilogram ipilimumab and 1 milligram per kilogram Nivo. So I'm not sure how easy it is going to be to tolerate 3 mg per kilogram of ipilimumab. I think that is something which people are worried about.
Yes, so logistics apart, that's the problem with STRIDE, sir. That's why it is a bear. But yeah, of course, looking at the ESMO Asia, definitely NevoIP is a fabulous option. Obviously, with regards to the logistic difficulty which you have pointed at right now. But NevoIP would be a winner definitely. STRIDE is not such a great data, I feel, sir. I mean, numerically also, it is only 16.3 OS.
Okay.
So I think it's not a great idea. It's only maybe a substitute to Etizolam and varicella and all that. But NevoIP would be a maybe we can call it a game changer.
So let me put it this way: how strongly do you believe in the whole data of the viral versus non-viral etiology and immunotherapy? Because Himalaya is the only one which has shown benefit on subset analysis in non-viral. IMBRAVE did not show any benefit in the subset analysis unplanned for the non-viral. So, Srinath, since you're talking about Etizolam and everything, this is where it did not show benefit. Would you think that matters?
Not very seriously, sir, but I think most of it was exploratory is what I feel.
Okay.
I don't think they have randomized it accordingly. So
it was not randomized. It was not randomized.
Really give so much of it.
Yeah. Okay. So, Dr. Rampralad, your thoughts on this same question about viral versus non-viral? Does it really matter?
Both viral and non-viral does not show any difference in the Himalaya trial, but IMBRAVE a little bit NASH people were not doing that well. Yes.
Okay. NASH cases are not doing, the non-viral etiology. So there is a Nature paper which kind of tried to show why this doesn't work, but that's the only thing. So, okay, there are a couple of questions going on there. So Dr. Sudhir is asking a couple of questions, which I will kind of break here and ask the panel. Before asking the panel, Dr. Rekha, your thought on the same discussion that we had of viral versus non-viral. And the other interesting thing, the role of CTLA. Tremelimumab is a CTLA inhibitor. Ipilimumab is a CTLA inhibitor, and definitely the toxicity does go up. So that's one thing which is a doubt.
Yes, sir. So coming to the viral and non-viral, until we don't have a proper representation, because most of the patients are viral. I mean, most of the patients
in India,
I'm in the trials I meant, sir. So until
30, it's around 1/3 each. So the non-viral in the I am brave is around 25 to 28%, if I'm not mistaken. So that they have been well represented.
I guess until we don't have randomized, we don't look at it in a way better than this, then maybe we'll be able to comment on that. For now, I'm going to, I mean, for now, until more data is there, I'll use it regardless. And talking about, yes, sir, ipilimumab will definitely add to toxicity. And I think CTLA-4 does come with its own toxicity. The couple of patients that I have given ipilimumab, it's a tough drug. So,
yeah, and this is I3. This is not I1. You know, in melanoma, it's I1, or in some other places where you give, for example, non-small cell, it is I1 N3. Here it is around, and you know, it's going to be a challenge here. It's I3. So I think that's the biggest challenge which I would foresee with this protocol. So Dr. Sudhir has been asking that in patients who have HCC, they will have some proteinuria, and does it make most patients ineligible? So Dr. Ram, your thought on that?
No ideas.
No idea. Would you ever test before giving bevacizumab for proteinuria? Or do you
No,
test
sir.
routinely in all patients during the bevacizumab?
No, sir.
No, okay. Dr. Shravan? Shravan, you're there? I can see that you're there. Dr. Shravan, not there. Okay, Dr. Shravan?
Sorry, sir. I was muted. Sorry.
Yeah. So
sir,
Go ahead.
I do monitor for proteinuria in all my BEV patients at least once in 4 weeks. Once in four cycles. Yeah.
Okay. I had a mental image of, you know, half of Vijayawada carrying a can of to collect their urine.
Sir, sorry.
Just to, you know. So,
no, sir.
All right. Okay. So yeah, I think we have been doing, and again, patients who are chronically on BEV, especially colon and ovary, yes, we have seen proteinuria, but I really don't agree with this statement of Sudhir that a lot of patients will be ineligible for BEV on the basis of proteinuria. I don't think that happens. It's not a big number. And there's no specific cutoff for BEV where you won't give it unless it is developed during BEV treatment. So that's that. And second question which he has asked is that many patients with HCC will have low platelets. So what's the cutoff of starting platelets? Again, we don't really have a cutoff. Anything which is reasonably okay, we give off. So I don't look at platelets if it is a chronic thrombocytopenia due to HCC. So like Santosh has mentioned that more than 50K we are fine. The answer is absolutely true. Control of beta blocker has to be there. You have to control the liver disease and the liver problems before you can go ahead with your atezo-bev as such. So that's that. Nikhil has commented upon the studies of viral seem to be more immunoresponsive, and the answer is yes. Possibly that's why the Himalaya and the Checkmate seem to be doing better there, because you're adding 2 drugs. You're not giving just a PDL1, you're giving a PD1 or PDL1, you're also adding a CTLA-4. So that's the explanation why it seems to be working better in those cases. So the other important point which I do think matters is about the VP4. So let me just get back to the panelists. Dr. Srinath, you look at the VP4, because remember, only study which included VP4 is actually the atezo-bev. So does that matter to you?
So sorry, I missed the question. There was a net problem.
I said, only trial which has included VP4. So when you're telling that we would use this versus that, the
Yes,
VP4 has been included only in the atezo-bev study. It is not included in other studies. They have excluded it. So does that make a difference to you? How common is that main portal vein thrombosis?
It's quite common, sir. But I mean, I think it shouldn't matter, sir. I mean, you can't really detect so much.
Okay.
So my main concerns would be mainly the varicose bleeding, sir. That's been my
Okay. I think you have been having bad luck. You have been seeing more of VP4 and you have been seeing more of variceal bleeding.
Correct,
So
correct, correct.
it's really bad luck. Because again, VP4 is not that uncommon. But again, like Dr. Sujana was telling earlier, you need a good MRI, you need a good imaging. Basically, most of the imaging as a reflex in medical oncology, we do PET CT, which unless you do a proper triple phase contrast, you will not pick up a lot of these findings. So
Yes.
unless your PET scan is doing that, I can tell you most of the cities in centers in Hyderabad don't do it. They do a single phase and they don't get any response from it. So that's about that. So I think the other point which I wanted to bring about, again, whether it matters or not. So Dr. Rekha, STRIDE has a 5-year update. And it shows that the benefit which is there for the STRIDE protocol is maintained. We don't have anything more than a 3-year update for the Etizobev. We don't know what's happening after that. Do you think that matters or both are good enough drugs? Or you think Etizobev is still good?
Yes, a long-term follow-up gives us more confidence in the combination, I mean, the Himalaya protocol. Somehow I've just used Etizobev and
Etizobev, so you're comfortable with it. So we have not used, to be very honest, Himalaya till now, though we have given a couple of patients durvalumab single agent for various reasons, and they seem to be doing okay so far. So this is about the product. So these are all the design studies. Interesting thing to note that all the studies have been done against sorafenib, with the exception of possibly the Nivo EP drug. And that is one more reason why Nivo EP might be a good protocol, because Nivo EP is done against lenvatinib or sorafenib. And the patients who have used almost half of. So, that is one study which seems to indicate that you could use it in a better way. I'm not going too much into this detail because, again, a lot of discussion, and at the end of the day, I think we have covered most of these, except for this 5-year overall update. So the 5-year OS is around 10 versus 3, which is a significant number, which is still there. And you're seeing that plateau. The most important thing is you're seeing that plateau, which is happening with the STRIDE protocol. The other things, these are the updated PFS, updated OS. I'm not really going into this. This is the NDW, which came this year in ASCO, and they found that around 85% actually received lenvatinib. So this for me is very important. All the other studies have compared against sorafenib. This is one of the only studies which has actually used lenvatinib as a comparator. And despite using lenvatinib as a comparator, it does seem to have slightly better PFS, though that is happening later. The median PFS is the same. Most Nivo EP studies, this is what you see. The PFS crosses, and that is exactly what you're seeing even in the 90W. You have a slight dip crossing, and then the PFS starts maintaining, which is what you see everywhere. Look at the OS. The median OS looks very nice. But again, look at this. This is a crossover. There's a slight kissing of the curves. And then you start getting this separation over time. And again, 3 year is possibly where you're finding a big difference. Whether this translates into a longer plateau, we really don't know. But like I said, the Asian subgroup is showing an excellent result. Toxicity-wise, Nivo EP, there were 12 treatment-related deaths. 13% of patients actually experienced discontinuation. So toxicity is not something we can be very easy about. So this is just a nutshell for all the trials. And again, as I said, Etizobev has PFS advantage and OS advantage, whereas the Durva-Tremi does not have an PFS advantage, has a OS advantage. Nivo EP does have a overall survival, again, no PFS advantage. Now, why in the Nivo EP you had such a long PFS in the comparator arm is again something that is quite unexplainable. I really don't know why you had, possibly because it was lenvatinib 85%. That's the only explanation we can think of. Because again, if you compare this study, which is the Pembro-Lenva versus Lenva, again, you had an 8-month PFS. So that's possibly the reason why you're getting these kind of results. There are new drugs coming up. You have camrelizumab plus rivorasenib. Again, this is an anti-VEGF, which seems to be improving the outcome. And we talked about this. One interesting collaborative study from many Indian centers headed by Anant showed that if you have trial-like and non-trial-like patients, means stick to the trial, those patients do well. They also showed that if you have some kind of these NASH, it did not really matter. You still had benefit with the etiology. This is our own data which was presented earlier. Now, this patient took Etizobev Now, this is the PET scan done after 3 doses, and you can see a very good response. This was the earlier disease. This is now. This is the enhancement and the large lesion which has reduced. Big reduction in this tumor size. So patient got 4 cycles till August. He developed ascites, insomnia with elevated bilirubin. So some dysfunction, gave steroids, rechallenged, again required low-dose steroids, continued with this. Now, after cycle 16, he again had grade 3 diarrhea. Now, the cycle 17 was given on this date and 18 was due last month. He's now admitted for the last 10 days in our hospital with some sepsis, and he's also having AKI with a creatinine which is just shooting up. So now we are thinking of immune-related nephritis, possibly. We are giving him steroids from yesterday. So I'm just crossing my fingers that this patient does well. But overall, if you see the course of action, this patient has been now doing well for 18 months on Etizobev. So 18-month PFS on one drug, of course, it's not everyone who does that, but the people who do well do really well. And that's the major thing that we need to discuss about HCC. That patients who do well will do well for a long time. And you can see this patient had a 13,500 AFP and it is now 3.8. So this is the kind of responses we see with immunotherapy. So I think that is all that I had to discuss in my presentation. Any questions from the panel, or we'll hand over to Santosh for the next slide, next session. So Dr. Santosh, over to you. He'll be moderating the next session.
Thank you, sir. Thank you, Rosh. Thank you, Vamshi, sir, for giving the opportunity. I think it's very difficult for moderating a session of so many wonderful talks and a spectacular moderation by Vamshi, sir. So being the last discussion, so we would have a very brief discussion and concentrate on those points that are not already discussed and more on the real world kind of scenarios. I would invite my extreme panelist, Dr. Nikhil. Are you there?
Yes, I mean, yeah.
Dr. Sudhir Reddy?
I am there.
Dr. Mahati?
Yeah, I'm here, sir.
Dr. Harshavardhan?
Sir, he's not joining because of some issues.
Okay. Dr. Rachna, ma'am?
I'm there, Dr. Santosh.
Yes, yes. I think we have most of our panel. We can invite inputs from other experts. So I think let's start with the case discussion. I would share my screen. So I would directly proceed with the case discussion. I think my slides are visible and everyone? So,
Yes, sir, your slides are visible.
So 55-year-old male, so had a history of past pulmonary tuberculosis and a reformed alcoholic and smoker. He is a diagnosed case of hepatitis C related chronic liver disease way back in 2017. He took antivirals and owing to that he sustained virological response. After which he lost to the proper surveillance protocol of screening for any development of hepatocellular cancer. And in December 2022, 2 years back, he presented with right hypochondriac pain and weight loss. He underwent evaluation. Triple phase scan showed a large space occupying lesion in the segment 5 and 8 with portal vein tumor thrombosis, which with a VP4 configuration extending to the main portal vein. And it was showing typical arterial enhancement and venous washout and background CLD with splenomegaly. Clinically, there is no ascites, encephalopathy. The initial report of AFP showed more than 50,000. On dilution, the absolute value was 1,57,000. The CBC and organ functions and INR were normal. So with this juncture, I would ask our extreme panelists, starting with Dr. Nikhil. Although this case is showing typical enhancement and washout, are there any scenarios in HCC where you consider biopsy?
Well, if there is a mixed imaging picture, then that is when I would do a biopsy. But in this particular case, since there is a possibility of impending rupture, I am little hesitant on getting a histological diagnosis.
Dr. Sudhir, is there any other case you would contemplate on doing biopsy? When
sometimes, yes, sometimes the picture of intrahepatic cholangiocarcinoma might be confused with hepatocellular carcinoma. If the radiologist says that there is an element of cholangiocarcinoma image wise, I think I would consider biopsy. If it is clear-cut case, I think I'll go ahead with the further management.
One important consideration is whenever the background liver doesn't show features of chronic liver disease or cirrhosis, in that scenario, we have to contemplate biopsy because biopsy can be obviated in cases where there is typical background cirrhosis, the nodule more than 1 centimeter, and the typical enhancement and washout. 3 parameters should be satisfied where we can obviate biopsy. Sometimes, Dr. Mahati, sometimes we have all these typical characteristics, but the AFP would be around 25 or 30. In that scenario, would you contemplate biopsy?
Yeah, if the AFP is also normal without background CLD, I would definitely do the biopsy.
Biopsy. Dr. Harshavardhan? He's not there, no? Dr. Rachana, ma'am, would you consider biopsy in any scenario that you have across?
Yes, we actually do biopsies in most of the cases of HCC because we have some experiences where the biopsy has shown a different histology. Recently, just 2 or 3 months back, we had a 27-year-old female.
Okay.
AFP, triphasic CT was suggestive of HCC. AFP was around 16,000. We insisted on biopsy and it turned out to be yolk sac tumor.
Oh.
So yolk sac, we know that AFP can be elevated there.
Madam, in that case, the background liver...
Background liver was normal. Yeah, that was not there. But still, most of the times, unless, not for this case where there is an impending rupture and all, but generally we do insist on getting a biopsy so that we are not missing out on something which are rare.
Yes.
And liver lesions also, it's not a problem to get a biopsy. So it is generally easily accessible tumors. So yes, we do insist on biopsies.
So, as our panelists have give various thought process on requirement of biopsy, whenever there is a typical cirrhosis background with nodule more than 1 centimeter and typical characteristics with elevated markers, most cases do not require biopsy. But of course, whenever the markers are not very high, background liver is normal, in this case, it's always prudent to do a biopsy and proceed. In our case, endoscopy was done and it showed grade 2 varices with red cherry signs. Overall, to summarize in our case, he's a case of hepatocellular cancer with major portal vein thrombus, VP4, BCLC-C, HCV-related CLD, child day functional status, grade 2 varices with red cherry signs, no history of previous bleeding, performance status of 2, and with an issue of risk of rupture. So in this context, in regarding to our particular case, I would request my panelists, starting with Dr. Nikhil. So how do you approach in terms of treatment? What protocol would you use, or would you use any special things apart from the standard of care? Dr. Nikhil?
I would definitely discuss this in a multidisciplinary tumor board.
Okay.
Esophageal varices, if there is a need for banding, then that would be discussed with the medical gastroenterologist.
It showed red cherry signs. It means that there are features that it might bleed. So that is what it shows.
So banding is needed, then we would go for it. We would also discuss whether any surgical intervention is needed with the risk of rupture of the tumor and the background portal vein thrombosis. I am not really sure.
Surgical intervention, you mean because the background liver is cirrhotic and it would not support any amount of surgery.
In that case, then the other option would be if at all logistics permit, tear. I don't know what the technique is. That can also be not. Then therapy would be there.
Okay, so Dr. Nikhil would consider tear some sort of local treatment. Along with what systemic treatment would you choose?
Otherwise, after the banding, then atezolizumab is okay.
Okay, after banding, you want to give atezolizumab. Dr. Sudhir Reddy, any other thing you would do, or what are your thought process on the management?
After addressing the varices with the prophylactic banding, maybe I would straight away and go start with systemic therapy.
Which systemic therapy?
The problem with atezolizumab.
Atezolizumab. Why not the Himalaya?
The problem with
because the patient
because of VP4 main portal vein is involved here. VP4, which is not the inclusion criteria of Himalaya.
Okay.
So that is one reason why I wanted to consider atezolizumab.
So there is an impending risk of rupture. So would you like to address it also along with systemic therapy, because the responses are not very aggressive or very not early, even if you consider atezolizumab also. So to contemplate or to avoid the risk of rupture, what additional features would you consider or discuss with the patient?
The problem with the local regional therapies is the patient already has got portal vein thrombosis. If you go and block the hepatic artery, the only feeding, the most of the times these normal liver parenchyma will be dependent on portal vein for the blood supply. If you go and block, I think we might end up causing hepatic infarction and causing decompensation of liver.
So you would not
that is the reason why I don't want to.
Regional therapy. So that's what you're telling.
Yeah. Yeah.
Dr. Mahati, we had a spectacular talk from Dr. Sujana. She was mentioning about role of radiation in case of HCC. Would you think this case we could give him radiation along with systemic therapy so that the initial risk of rupture we could prevent? What are your thought process on it?
I think the size is more than 10 centimeters, if I'm not wrong. So in such a huge masses, I would ideally not go for SBRT with the data available at this juncture. Upfront SBRT.
Okay. So which type of systemic therapy would you adopt in our patient?
In this particular case, ideally, first we will address the endoscopy, and I would rather start off with the single agent atezo with the option to add on BEV at a later stage.
Okay. I think Dr. Sujana is with us. So I think we will take her opinion. This is the description of the lesion.
Yeah, I've been hearing the discussion, Santosh. I just
yeah.
stopped my video. I kind of have seen it. So this looks like a multifocal tumor to me. The lesion is quite big.
Okay.
So yeah, unless we are kind of looking at a palliative setting where you can treat the whole liver with a single 8 grade for a pain control or something. Otherwise, with a curative intent, I don't see a reason why we should treat with SBRT. No.
Right. So with that input from radiation oncologist, Dr. Rachana ma'am, so how would you treat this case after eradication of varices? So how long would you want to wait starting systemic therapy, and how do you approach?
If the varices are being, we are not having an active bleeding. We are just doing a prophylactic banding because there are Red Cross signs. So I don't think we need to wait to start bevacizumab. Because of a well-controlled varices, we don't need to wait to start bevacizumab. Okay. So yes, we can start them together, atezo plus bevacizumab. One option, I don't know if anyone has any experience of hepatic arterial infusion of the chemotherapy, which we generally read, but no experience from my side. But can that be used in such a cases of with the risk of rupture? Is one thing I would contemplate for such a condition.
I haven't used, ma'am. Vamshi sir, your experience in it? I think we'll proceed.
So we have not used it, and the HIA best data is actually for liver mets and other things, not for HCC as such. Okay. So it's better to possibly do a TACE or a TARE, and we have multiple options anywhere there.
Okay.
But with the portal vein thrombosis, maybe TACE would not be a possibility, right?
Not TACE, we can do SBRT or we can do TARE.
TARE is, TARE we can consider, yes.
So again, I have to tell that TARE trials have also excluded VP4 in most cases. So again, when you see PVTT, please understand that when the TARE doctors are saying that yes, we can do with PVTT, it's mostly in VP2 or VP3. VP4 specifically inclusion into TARE trials is very less. So, the only thing which actually works is SBRT. So, or immunotherapy.
Yes. So especially with VP4, the problem is the shunt fraction becomes more with TARE. The max scan shows more than 20 or 30% shunt. That becomes extremely difficult. So that is the reason in VP4, even TARE is actually difficult. So I have a few real world scenarios. Suppose the patient had a previous bleed. Of course, our patient did not have a previous bleed. So I want quick inputs from our panelists. So first cycle, would you include bevacizumab after this one, or you would go the Himalayan way? Dr. Nikhil?
The previous bleed is because of varices and that has been addressed, then that's okay to go ahead. I don't see the point of waiting for it.
Okay, okay. Suppose after 2 cycles of atezo-bev, the patient had a bleed.
So again, I would check for the cause for the bleed, whether it's a gastritis or varices or what.
Varicose. It is varicose bleed.
Is varicose, then I'm a little hesitant to, I might skip for a couple of cycles and then do.
You would continue single agent atezo and later you would analyze. That's what you would do. Dr. Mahati, suppose you have given 2 cycles of atezo-bev and the patient had bleed. So how would you decide the further continuation of atezo-bev?
Yeah, I would address the bleed, and once the thing is done, I will wait at least for 6 weeks before I restart BEV. In the meanwhile, I'll continue with that. So that's what we.
For maintaining the intensity of the treatment, would you consider doing something like lower dose of bevacizumab, or in place of bevacizumab, give some TKI?
Not aware of it. Haven't practiced it like that.
Rachana, ma'am?
When there is an active bleed, I would not be using bevacizumab at that particular point of time.
Okay.
As you said, there is for TKI, maybe yes, I would consider hiding it, but there is no data for that to support it because you're not able to give bevacizumab. Maybe we can try and see, but that would be a case-to-case basis.
Yes. So I was reviewing the literature. Suppose the patient had a bleed in between this one, they would stop from 1 cycle, and the subsequent cycle they either added a TKI or used a lower dose of bevacizumab in dose of 5 mg per kg. So the another quick question to all my panelists: what is the bevacizumab dose you use combination with atezo-bev? Dr. Nikhil?
It's 15 mg per kg.
Dr. Sudhir?
15, sir.
Mahati?
Let's start off with 15, sir.
Rachna, ma'am?
15 mg per kg.
Yes. So I think the dose is 15 mg per kg, but there is some data that the patient has bleeding. You can slightly come down on the doses.
Dr. Sorry to interrupt. Is there any dose relationship to the bleeding outcomes?
So what they have seen is it was a retrospective analysis of around 15 patients who had bleeding. When they have reintroduced with 5 mg per kg, so they did not have subsequent bleeding after successful eradication of varices and waiting for 1 month. This is what the retrospective data of 15 patients showed. So we don't have a prospective as of now, but this is what I could find how to manage a patient who had bleeding after atezo-bev.
Okay, sure.
So we had a discussion during Vamshi sir's panel discussion of active hepatitis B, C. One more thing is if the platelets count are good, suppose more than 1.5 lakh, and you have eradicated varices, in presence of VP4, would any one of the panelists contemplate on adding anticoagulation? Dr. Nikhil?
No, in case of tumor thrombus.
Okay. It is a portal vein tumor thrombosis also has some amount of thrombus also. It's not completely tumor. Patchy FDG uptake is present in the thrombus. So in that scenario, would you add some anticoagulation?
We are really not doing in practice. Yeah.
Dr. Sudhir?
I'm not doing.
Dr.
Can I make a point here,
Yes,
Dr. Santosh?
Yes.
So especially when patients like these, because we keep dealing with a lot of these patients, they have a very bad ischemic pain because of the portal vein tumor thrombus, really bad pain, and they come with a very typical abdominal and pain which is radiating to the back. So especially for these kind of patients, adding DOACs and assessing them after 2-3 days really helps. We've seen like in the clinic, we've seen that. And I think probably it would be wise if we add it. I mean, sorry to kind of get in between, but yeah, that's what our experience is.
Point well taken, but we should be very sure that the varices are completely eradicated.
Yeah.
And the hypertension is controlled, and we give bevacizumab and all. This is the second thing, and platelets remain more than 1.5 lakh because the patient have a portal hypertension and all. There is no strong data supporting to it, only case-to-case basis. Rachana ma'am, suppose there is a case, there was VP4 thrombus, but no FTG uptake in the thrombus. In that scenario, would you consider adding some anticoagulation?
First, I would like to see the liver functions also because we have a deranged liver for most of our HCC patients.
Yes.
So the coagulation profile is also deranged. The PT, INRs, everything would be deranged.
Yes.
So using anticoagulants at that point of time, considering it to be a normal thrombus, not a tumor thrombus, it would be a risk versus benefit thing which we have to consider.
So always anticoagulation is a controversial area in this where we have the risk of bleeding is very high. So in very selective case-to-case scenario, as Dr. Sujana has emphasized, maybe we consider, but be very careful. Dr. Vamshi sir, any point on this? So these points we have discussed that etiology influencing the treatment decision and all. So I will not go into it. Our patient has received 3 cycles of atezolizumab, bevacizumab. After 3 cycles, PET scan showed partial response and more or less stable disease. And if you see the AFP marker wise, 1,50,000 was there. Now it has decreased to 1,07,000. Definitely the pain and all stabilized. So when do we expect response in case of immunotherapy? After what cycle should be the ideal assessment? Is it after 4 cycles, 3 cycles? Dr. Nikhil, what do you think?
After clinical assessment, somewhere between 3 to 4 cycles is what we usually practice.
Yes. So suppose after 3 to 4 cycles, the markers are almost same, maybe variation of 10,000, and the PET scan showed stable response. In that scenario, would you contemplate or changing something or continuing?
No, if the patient is clinically well, symptoms have come down, minor fluctuation of AFP, I would really not bother on.
Okay. Dr. Sudhir, at what is the time that you would consider this one?
4 cycles. 4 cycles.
Dr. Mahati?
4 cycles, sir, with
Achha,
immunotherapy.
ma'am?
4 cycles for patients who are clinically responding.
Yes. So in that, in our case, we continued 3 more cycles of bevacizumab. This is the after 3 cycles. This is after completion of 6 cycles, where you can see there is good response in terms of tumor, but there is streak of uptake in the portal vein thrombus area. So this is the tumor response. After 6 cycles, there is spectacular response. As we have seen in many cases, the response with immunotherapy tend to have slow. So that is what is seen in our case. So patient completed 6 cycles with good response on PET scan, and the AFP response is good and in a good performance status at this juncture. So how to proceed further? Dr. Nikhil?
With the slightly rising AFP or?
This is normal AFP.
Normal. I think we'll continue.
You'll continue.
Or we can discuss maybe doing some loco-regional therapy further since it had a very good response.
Okay.
Maybe.
And the patient asked, should I take lifelong treatment?
I really don't know that.
Okay. Dr. Sudhir, your point of view at this juncture, patient asks, how long should I take the treatment? Is there anything you can do, Doc Saab? What would be your point of view in this scenario?
The treatment has to be continued since there is a response.
Okay. Would you add on some loco-regional therapy because there is fantastic response, as you can see, and give him some respite of some curative option, or should we not think because the burden was very huge, 10 centimeters?
No, the tumor has come down and the symptoms, patient is relatively asymptomatic. There is no point in giving loco-regional therapies.
Okay. Dr. Mahati, do you have other viewpoints or you agree with the other panelists continuing systemic therapy without doing any loco-regional therapy?
No, we'll definitely have a multidisciplinary discussion and I would give them an option of loco-regional therapy. But then I would also counsel them that even post loco-regional therapy, probably they might have to continue with the immunotherapies. Not curative.
See, for this case, which has a response, and if the patient is not willing to continue atezolizumab for a longer period of time, maybe I would ask radiation oncologist to give an opinion if they can do some SBRT for this reduced lesion.
We have radiation oncologist.
Yes, Dr. Sujana is with us.
Thank you, Rachna, for asking. Yes, I'd be glad to treat this patient.
But the thing is, we have to put in mind that he had a portal vein tumor thrombosis and a huge mass. So he may not do well as a patient who actually presents with such a disease upfront, not after giving atezolizumab. So that we don't know how long the response would be lasting for such a patient who initially presented with a huge burden of the disease. So keeping that in mind, we have to counsel the patient and maybe we can plan for SBRT if Dr. Sujana is ready to give it.
Yeah, absolutely. I'm ready. I'm just sitting here and.
But again, I think that there would be significant microscopic disease which will be sitting despite all the loco-regional therapies we do. So it still remains palliative only. So we need to discuss those things also. Yeah.
So these were the exact thought process we had in our mind at this juncture after completion of 6 cycles. Should we go all palliative, continue systemic therapy, do not do any local regional therapy, or go something aggressively, do local regional therapy and wait and watch? We reviewed the literature and all. Those patients having such kind of spectacular response in tumor response, there was data of aggressive therapy. The treatment of HCC has become more of there is no strict transplant criteria. It has been revision from the original Milans to other. It's always a metro ticket kind of model where you get advantage based on the extent of disease and control. So even the systemic therapy is considered a downstaging measure. So with this thought process, what we discussed with the patient, of course, there would be some risk of relapse. We want to give loco-regional therapy. At that time, we would allow some amount of washout of immunotherapy so that we can contemplate further. So this was the thought process. At this scenario, we gave, as Dr. Sujata opined, SBRT to the primary liver lesion, and also we have given to the portal vein tumor thrombus. This has allowed us a wait and watch period of approximately 1.5 months. We did not give the subsequent 7 cycle of atezo-bev. So respiratory gating and IR kind of protocols they have followed. So after this, there was spectacular response. So you can see after completion of SBRT and this one, after approximately 2 months after SBRT, we have done. So at this juncture, how to proceed further, Dr. Nikhil?
So I think the plan was made earlier before doing RT that what would be doing subsequently. I think there are two options for it. One is to wait and watch. If the disease comes back, then maybe rechallenge if there is a significant amount of time between the last dose, or if it comes out quickly within 2-3 months, you can always try that or change therapy.
Okay, Dr. Mahati.
Yeah, as I previously said, I would have counseled them for continuation of immunotherapy. So even with this, I would go ahead and continue if they are willing.
Yes, so you would continue immunotherapy. So we had again another doubt. There was one particular node in the mediastinum that keeps lightening across all scans. Although the primary reduced, this was continues to be lightening up. So before taking the major decision, we did a bronch and sampled. It was an inflammatory thing. So that gave us a conclusive that the extrahepatic disease, the microscopic extrahepatic disease, we are at least conclusively eliminating it. Dr. Rachana, madam, at this juncture, what would be your thought process? We have waited almost 2 months without systemic therapy. The markers are fine. The PET scan shows normal. After RT, even the tumor thrombosis does not show any uptake. So what would you consider in this scenario at this juncture?
I would consider discussing with the patient, and if they are willing to continue, I'd continue with atezo-bev. Not willing to continue, I'd put them on close follow with the tumor markers and imaging as required. And whenever it comes back, I would re-challenge with the atezo and bevacizumab.
Because the patient has CLD with portal hypertension also. Would you give them an option of liver transplant at this juncture?
That would be a very huge step for this patient with the huge burden of disease initially, though now responding. We don't know. We do have some stories of immunotherapy curing the patients in other solid tumors also. But liver transplant would be something which would be a very big step, I would say.
Other panelists, anybody would contemplate on at least thinking on liver transplant?
Yes, I think that also has to be brought onto the table. But I think waiting for some more time will help us in understanding the disease biology, and then yes.
So how much is that waiting time?
I really don't know. I'm not but at least a multidisciplinary discussion would be done.
So this was the exact question that we had. How much time should we wait? So we reviewed the literature. 5 T-halves of atezolizumab was what that we have considered in our case. So let the immunotherapy wash out. We waited for around 2.5 to 3 months. Later, he underwent liver transplant with daughter. So this is the explant liver specimen where it showed complete clearance of all the tumor. On histopathology, you can see there is only hyalinization. There was no viable tumor that is there. So now almost post liver transplant, He is around 1.5 years. The subsequent scan and markers continue to be in response. Hope that the patient would have long-term durable response. So this is one of the experience that I want to discuss and have inputs from other things. So I think we crossed a little bit.
What do you think worked, Santosh? SBRT worked or immunotherapy worked?
Madam,
The complete
effect, as
necrosis.
you have told, abscopal effect. So both in tension. So
So
I think
medical oncologists have more faith in us.
yes. So the thing is, especially for cleaning the portal vein tumor thrombosis, radiation has a very important role actually. Whatever systemic therapy, especially the clearance of portal venous tumor thrombosis, we think that radiation is a must before proceeding to aggressive treatment in form of liver transplant and all.
Yeah. On contrary to the very popular conventional belief, actually, there were a few tumors like melanoma, sarcoma, and RCCs. They used to say that they are HCCs. They used to be, the whole belief was they're all radio resistant. But HCC is like completely different ball game. They are very radio sensitive, and even though if it's a palliative setting, also they have a very good symptomatic relief.
In ablative doses, anything is radiosensitive, I think. That's what, little.
No. What I'm trying to say is it's contrary to the popular belief, they're very radio sensitive. Even for a very small 30 grain 10 fractions also, they do miracles and wonders.
So it's always multidisciplinary contribution that helped in our case. We had this constant discussion of curative versus palliative, how long to continue. It was a constant discussion with the patient, family, and all the team before treating this patient. Thank you, my esteemed panelists, and for chipping in, Dr. Sujana. And thank you very much, Dr. Vamshi sir and Rosh, for providing this opportunity. Thank you.
Dr. Sant, 1 or 2 questions.
Yes.
So, so you said that you waited for about 5 half-lives of Atizo. What were you really looking in when you were waiting for that?
We gave this radiation.
Yes.
So we want to control the remaining locoregional disease. So during the wait period, we gave local radiation to the portal vein tumor thrombosis and tumor bed. That gave us a window of opportunity to wait with more confidence.
Okay. No, you said that it was about 5 T-halves of Atizo.
Yes.
What were you really looking at? That the effect of immuno is gone, still the disease hasn't come back, or?
We waited because we don't want a rejection. We were worried that post-immunotherapy, doing a liver transplant might have a donor rejection and all. That is what the liver transplant team worried. So we were looking at the literature and all. So there was data. At least they wanted to wait for at least washing out of the immunotherapy.
And in a very unfortunate situation, if it recurs after transplant, then the role of immunotherapy, what would you do?
So we have reviewed the literature at that point of time only. Rechallenging immunotherapy is a very tough decision. There is 40% chance of donor rejection. So there is, of course, option of TKI and all that are there. Luckily, we should not anticipate that. But if occurs, we discussed with the family with also option of lenvatinib and TKI is what we considered. So this is what we have reviewed the literature.
Sure. Thanks.
Thank you.
Thank you, everyone. I think that's all from my side. Over to Dr. Vamshi, sir. Dinesh, can you take over? Technical team, anyone?
Samar?
Yes, sir. Dr. Vamshi, can you hear us?
Dr. Vamsi is present in the meeting, sir.
Okay.
I think we can wait for him to conclude.
I think Dr. Vamshi.
Samar, can you call up Dr. Vamshi?
Yes, sir. Calling, sir.
Just a second, please.
So, sir, Dr. Vamshi might like got busy somewhere. Dr. Sujana can give the closing remarks. Hello.
Someone
Hi.
check the presence. Yeah. Yes, ma'am.
I think most of the doctors have left. In that
Okay.
case, I think we can conclude with the meeting, and all the HCPs who are still present in the meeting. So, Ross would like to extend our thanks for your taking out your valuable time for this meeting and re-establishing this A plus B regimen as the first line in HCC. Thank you.
Thank you, ma'am.
Thank you so much, ma'am. Thank you.
Thank you, sir.